Neurology quiz number 86. Describe the pathogenesis, clinical features, and management of the antisynthetase syndrome. The antisynthetase syndrome is one of the causes of inflammatory myopathy along with polymyositis, dermatomyositis, and immune necrotizing myopathy. It is a multi-system autoimmune disease characterized by autoantibodies against an amino acyl transfer RNA. Clinical features can include the following: interstitial lung disease, non-erosive arthritis, myositis, Raynauds phenomenon, mechanics hands, fever. Two or more of these manifestations are usually present. Myositis in muscle weakness is not seen in all patients but is encountered most frequently in patients positive for the anti-JO1 antibodies, with myositis being reported in up to 90% of such patients. Clinical features of myositis are similar to other causes of inflammatory muscle disease, with subacute weakness of proximal muscles that develop over weeks or months. Weakness is usually symmetric, and patients report difficulty doing tasks requiring use of proximal muscles, such as rising from a chair, climbing stairs, or raising their arms to lift objects. Involvement of neck muscles and trunk muscles can occur. Pharyngeal muscles may be affected, with nasal speech, dysphagia, and nasal regurgitation. Mechanics hands are a characteristic skin lesion seen in this condition. These consist of hyperkeratotic lesions along the radial and palmar surfaces of the fingers. Some patients may have skin lesions similar to those seen in dermatomyositis. This figure shows an example of mechanics hands with hyperkeratotic lesions along the palmar and radial surfaces of the fingers. This picture shows an example of Raynauds phenomenon, and the other picture shows polyarthritis. Polyarthritis and antisynthetase syndrome is non-erosive. That means it does not destroy cartilage or subchondral bone. Diagnosis: serum CK. Serum CK levels can be markedly elevated during the active phase of the disease. The transaminases AST and ALT, which are also present in muscle, may increase. Antisynthetase antibodies. Amino acyl transfer RNA synthetases are enzymes that catalyze binding of specific amino acids to their cognate transfer RNA. Currently, 8 such antibodies are recognized, as shown below. Anti-JO1. Here, muscle involvement is common. There is progressive interstitial lung disease, may have mild skin rash and mechanics hands. Anti-PL7. Severe interstitial lung disease, may have moderate muscle involvement. Anti-PL12. Severe interstitial lung disease, may have mild or no muscle involvement. Anti-EJ, anti-OJ, and anti-KS has high association with ILD, and anti-ZO and anti-HA is rare with possible ILD. Anti-JO1 is associated with the greatest risk of developing myositis, and those with PL12 antibodies have the highest risk of ILD. This image shows a CT scan of the chest showing interstitial lung disease. EMG in patients with myositis. This reveals a myopathic pattern with small amplitude, brief, polyphasic motor unit potentials, and early recruitment. Muscle MRI can show intramuscular stir hyperintensities, as in other types of myositis, but no specific pattern has been described. Pathology. This may reveal distinct features like perivesicular necrosis, perimysial fragmentation, and aggregation of nuclear actin on electron microscopy. Perivascular atrophy and microvascular abnormalities similar to dermatomyositis can be seen. This is a picture of a muscle biopsy H&E stain, which shows necrotic fibers and myophagocytosis, predominantly of the perivesicular fibers. Perimysial connective tissue is fragmented and edematous. This picture shows axial and coronal MRI images stir sequence in myositis, which shows hyperintensity in the muscles, indicative of edema in the muscles, period. This picture is seen in any kind of myositis and is not specific for a particular type. Treatment. This is similar to treatment for other inflammatory myopathies. Corticosteroids are usually first-line therapy in a dose of 60 to 80 milligrams per day. If muscle weakness is severe, IV methylprednisolone 1 gram a day for 3 to 5 days can be given initially, followed by oral prednisone. Steroid tapering should be started only 4 to 6 weeks later, and doses should be decreased by 5 to 10 milligrams every 2 to 3 months. To avoid long-term effects of steroids, a steroid-sparing agent should be started in patients with moderate to severe disease. These include azathioprine, mycophenolate, or IVIG. Methotrexate should be avoided because it can cause ILD and has the potential to worsen lung disease.